So, what is the difference between the acute kidney failure and acute kidney injury? Previously, it was called the acute renal failure. Now, it is called acute kidney injury. Why? Because renal failure means the failure of the system, but in case of the acute kidney injury, that is the short term disease, and we can reverse the disease by intervening with proper medication and with or at the proper time. That is most important to reverse the acute kidney injury. So, what is acute kidney injury? Acute renal failure is a clinical syndrome, not a signify a specific disease, but a group of disease or a clinical syndrome in which a sudden deterioration in renal function. What is the function? Kidney function, main kidney function is the maintain the fluid and electrolyte homeostasis in our circulation. So, this is a clinical syndrome in which sudden deterioration of renal function resulting inability of the kidney to maintain the fluid and electrolyte homeostasis. Because it can be reversed with the treatment at the acute renal failure at the proper time and proper management. So, now it is called the acute kidney injury. Any patient admitted in NICU, critical care unit, NICU means neonatal intensive care unit, and PICU, that is the pediatric intensive care unit or ICU, adult ICU. Any critical care unit, patient admitted, we should monitor the, along with heart rate, saturation, blood pressure, we should monitor the urine output to early diagnosis of the acute renal injury or acute kidney injury. What is the normal urine output of a patient? Normal urine output of a patient in case of the pediatric or in case of the adult, koto? When we called it is oliguria, when it is called polyuria, 2 to 3 liters, that is the adult measurement. আর কিভাবে মেজার করা যায়? How we measure the urine output? Because body weight is different, and we can measure the urine for 6 hours, for 12 hours, for 20 hours. You are telling about the urine output of a adult over 24 hours period. But to detect early, we can measure urine output for 6 hours to stamp as a case of acute kidney injury or acute renal failure. তাহলে how we measure the urine output? ml per kg per hour basis, or the ml milliliter per kg per hour basis. So 0.5 to 5, 0.5, generally 1 to 3 ml per kg per hour is normal, but if it is less than 0.5 ml per kg per hour, then it is called oliguria. If it is more than 5, polyuria. Very good, polyuria. What is the common cause of here? Polyuria? Diabetic, very good. Diabetic mellitus and diabetic insipidus also. Diabetic mellitus আমরা কি হয়? Polyuria. Polyuria, polydipsia, polyphagia. That is the so many poly in case of diabetes mellitus. So if it is the less than 0.5 ml per kg per hour, it is oliguria. So generally acute renal failure occurs 2 to 3% in children admitted in pediatric tertiary care and 8% of infants in NICU, neonatal intensive care unit. And it is due to the pre-renal or renal or post-renal cause. Pre-renal means before the kidney, and renal means within the kidney pathology or the kidney involvement, and post-renal after the pelvic calcium junction, that is the in the ureter or maybe in the urethra or maybe in the bladder, that is the post-renal after the kidney. যে কোনো কালেক্টিং সিস্টেম যদি হয় in the ureter or urethra or the bladder, that is the post-renal. Pre-renal means before the kidney. Now that is the causes of the acute renal failure, either pre-renal, intrinsic or the post-renal. And intrinsic is the glomerular or tubulointerstitial. Glomerular pathology may be primary due to primary cause or due to the secondary cause or due to the deposition of the immune complex, that is the secondary cause. Previous class we will discuss about the acute post-streptococcal glomerulonephritis. There is the deposition of the immune complex in the glomerulus, that causes the acute renal failure. Now that is the main pre-renal, intrinsic and the post-renal. What are the pre-renal cause? Pre-renal means pre-renal, renal and the post-renal. Pre-renal, any idea about the pre-renal cause? Post-renal is the obstruction in the urinary tract, either in the ureter or the bladder or the urethra. That is the simply the obstruction of the outflow tract of urinary system. PSGN is the affecting the kidney, post-streptococcal glomerulonephritis. That is the renal cause by intrinsic cause of the acute renal failure. I am asking about the pre-renal cause, means kidney is not involved. Vascular obstruction, very good. Vascular obstruction means there is the decreased renal blood flow or the decreased glomerular filtration rate. So any cause affecting the glomerular filtration rate or the blood flow to the kidney can cause the acute kidney injury, that is the pre-renal. In case of vomiting, in case of diarrhea, that is the most common. Acute gastroenteritis, multiple episode of vomiting, multiple episode of diarrhea causes the dehydration, severe dehydration, and that causes the hypoperfusion of the kidney, and that leads to the acute kidney injury, and that is the pre-renal. Any cause of the decreased blood flow to the kidney causes the pre-renal cause of the acute kidney injury. Classification or staging of the acute kidney injury. You will remember the first one. If the increased serum creatinine level is 0.3 milligram per deciliter or increase by the 150 to 200% or 1.5 to 2-fold increase from the baseline of the creatinine level, that is the lab parameter. Diagnosed by the lab parameter or by simply measuring the urine output. Or if the urine output is less than 0.5 ml per kg per hour for more than 6 hours, then we can call it is a acute kidney injury. If serum creatinine is more than equal to 0.3 milligram per deciliter increase or 150 to 200% increase from the baseline creatinine. So we measure the creatinine at 2 instants. We should know the basic creatinine level. If there is the increase of the creatinine level from the baseline, 1.5 to 2-fold rise of the creatinine level, then we call it is an acute kidney injury, or simply by measuring the urine output for more than 6 hours. If it is less than 5.5 ml per kg per hour for more than 6 hours, then it is a AKI or acute kidney injury. You remember the first one only. So common causes of acute renal failure, that is the dehydration. In case of the trauma with several amount of blood loss, that causes the hypoperfusion or to the kidney, that is the hemorrhage, sepsis, hypoalbuminemia. Hypoalbuminemia in case of the nephrotic syndrome. nephrotic syndrome, hypoalbuminemia. That is a condition of the volume overload, but effective volume, intravascular volume is less in the hypoalbuminemia. In case of the liver failure, in case of the nephrotic syndrome, that can cause the acute kidney injury, but the total fluid in the body is more. Intrinsic cause, that is the post-streptococcal or post-infectious, lupus, SLE, HSP, membranoproliferative or anti-GBM. There are many causes affecting the glomerulus or the interstitial space that cause the intrinsic causes of the acute renal failure. আগের দিন যেটা পড়লাম যে পোস্ট-স্ট্রেপ্টোকক্কাল গ্লোমেরুলোনেফ্রাইটিস, SLE, HSP, হেনক্স কোলেন পারপিউরা, এখানে কি there is the purpuric spot over the extensor surface of the lower limb, mainly the lower limb, affecting the kidney and presented with the hypertension, pain abdomen, blood in stool. That is the presentation of the HSP. Membranoproliferative disease, anti-GBM. There are so many causes of the intrinsic causes of the acute kidney injury. What is the acute tubular necrosis? Acute tubular necrosis, it is the most common cause of intrinsic renal failure. If we don't treat the acute dehydration or the hypoperfusion at the right time, then hypoperfusion to the kidney or the glomerulus persist. That causes the acute tubular necrosis. In case of the toxin or drug, acute insult to the kidney by the toxins or by the drugs can cause the ATN, acute tubular necrosis. Most common cause of the intrinsic renal cause of the acute kidney injury. Renal vein thrombosis, rhabdomyolysis, acute interstitial nephritis. Renal vein thrombosis কিভাবে clinical presentation may present with hematuria, pain abdomen and the palpable renal mass. Renal vein thrombosis, there is the enlargement of the kidney, palpable renal mass, hematuria and the pain abdomen, hematuria and this is the post-renal causes of the acute kidney injury. Any obstruction to the urinary outflow tract can cause the acute kidney injury. যে কোনো হতে পারে, in the urethra, posterior valve, in case of the vesico-ureteric junction obstruction, renal stone, any cause, any tumor, that causes the obstruction of the urinary tract and cause the acute kidney injury, or it is the functional obstruction to the urinary outflow tract, that is the neurogenic bladder hemorrhagic cystitis. In case of the neurogenic bladder, there is no mechanical obstruction, but there is the functional obstruction, difficulty to evacuate the urine due to the neurological cause, that can cause the acute kidney injury. Okay, posterior valve কাদের থাকে? In case of the male or female? Female. কার থাকে? Male or female or both? Male, female or both? Posterior valve is a disease of male, female or both. You have read the anatomy, na? Posterior valve is a disease of male, female or both. Hero, male, female or both? এখন গুগল সার্চ দিচ্ছে নাকি? পরে বল। হ্যাঁ, both. male, female or both? Congenital, very good. Congenital obstruction of the urinary outflow tract, but it is a disease of male, female or both. Okay, female. Posterior urethra present in the female or not? Posterior urethra present in case of the female or not? First tell me. থাকে posterior urethra? হ্যাঁ, posterior urethra থাকে? এটি গিয়ে পরে পড়িস। Why there is no posterior urethral valve in case of the female? There is no posterior urethra in the anatomy. Only the anterior urethra. There is no posterior urethra in the case of the female. So that's why any obstruction or intermittent obstruction of the urinary tract, urinary flow, bladder is full, and there is no kidney pathology. In case of the male child, male newborn, 1.5 months or below the infancy, we can suspect about the posterior urethral valve. In case of the girl baby, we don't think about the posterior urethral valve. No posterior urethra, so no posterior urethral valve. Laboratory findings to differentiate between the pre-renal and the intrinsic renal failure. Before the treatment and the pathology is different in the pre-renal and the renal pathology. In case of the pre-renal, there is the hypoperfusion of the kidney or the glomerulus. Right? So there is the kidney try to retain the fluid to the body because there is the decreased blood flow to the kidney. So urinary concentration is increased in case of the pre-renal. Mainly pre-renal cause due to the hypoperfusion, that is the volume depletion from the system, either effective volume depletion or the real amount of the volume depletion by hemorrhage or the acute gastroenteritis. So kidney try to retain the fluid and urinary concentration increased. And in case of the acute kidney injury, urea will increase more than the creatinine. Urea will increase more than the creatinine. And in case of the chronic cases or intrinsic or renal pathology, creatinine will increase more than the urea. It is very important to differentiate between the pre-renal cause and the renal cause because treatment is totally different. Pre-renal cause we treat with the IV fluid or simply by the volume repletion to the system by giving the IV fluid or the diuretics. So if the urinary sodium is less, so body try to retain the fluid and the sodium in case of the pre-renal because there is the volume depletion status. So it is less than 20 in case of the pre-renal and more than 40 in case of the intrinsic kidney injury. And urine osmolality increase in the pre-renal, that is the more than 500, and decreased in case of the intrinsic renal failure. And urea, blood urea nitrogen and creatinine level, that is more in case of the pre-renal and less in case of the intrinsic AKI. এটা জিজ্ঞেস করে লিখে নেই how you differentiate between the pre-renal and the intrinsic renal failure. If there is the hypoperfusion, যদি কিডনিতে কম ব্লাড সাপ্লাই যায়, if there is a decreased blood flow, kidney try to retain the fluid and the electrolytes to restore the volume. ব্লাড ইউরিয়া নাইট্রোজেন তো বাড়বে, কিডনি তো ইউরিন মানে ইউরিয়াটা বার করতে পারছে না, টু এক্সক্রিট দ্য কান্ট এক্সক্রিট দ্য নাইট্রোজেন এক্সক্রিয়েটস, ব্লাডে বাড়ছে, not in the urine, that is the blood urea nitrogen or the creatinine in the blood, that is not in the urine. এখানে লেখা আছে না blood, that is in the blood, not in the urine. Blood মানে ইউরিয়া by creatinine ratio, that in the blood. So, pre-renal causes of the acute kidney injury due to the decreased arterial circulation, circulatory volume, inadequate renal perfusion and the low GFR. If the hypoperfusion persists, then it causes the intrinsic parenchymal damage of the kidney. If hypoperfusion sustained, that is the intrinsic parenchymal damage. So, pre-renal cause of the AKI can cause the intrinsic renal injury or intrinsic renal causes of the acute kidney injury if not intervened at the proper time. So, pre-renal cause decreased circulatory volume, inadequate renal perfusion and the low GFR. If underlying cause is reversed, renal failure returns to normal. So, timely intervention is very helpful to reverse the acute kidney injury due to the pre-renal cause, due to the acute gastroenteritis, acute hemorrhage or the hypoalbuminemia, cardiac failure, any causes. So, any patient admitted in the NICU, PICU or ICU, we should monitor the urine output to early detect the renal failure. Etiology of the pre-renal causes, that is the intravascular volume depletion already discussed, and the abdominal compartment syndrome. What is the abdominal compartment syndrome? Abdominal compartment syndrome is the increase of the intra-abdominal pressure due to any cause, due to trauma, due to tumor, due to aneurysm, rupture of the aneurysm, any cause, sepsis, any cause. If increase the abdominal compartment syndrome, that causes the renal hypoperfusion, causes the acute kidney injury. So, any cause increase the intra-abdominal pressure, that is the abdominal compartment syndrome. Due to the rupture of the aneurysm, many times rupture of the aneurysm, any tumor, trauma can cause the abdominal compartment syndrome. What is the classical features of the pre-renal acute renal failure? That is the absence of the cellular injury. There is the no cellular injury in case of the pre-renal acute kidney injury. That's why prognosis is excellent in case of the pre-renal acute kidney injury. There is the no cellular damage due to the pre-renal causes of the acute renal injury. So, the defining features of the pre-renal ARF is the absence of cellular injury and normalization of the renal function with reversible of the altered hemodynamics factor. Pre-renal prolonged hypoperfusion can lead to the acute tubular necrosis. It is the most common form of the acute intrinsic cause of the acute renal failure. It is due to the nephrotoxic drug, ischemic or the multifactorial. Any drugs, nephrotoxic drug can cause the acute tubular injury. Snake bite, venom cause the acute tubular necrosis. Prolonged hypoperfusion cause the acute tubular necrosis. So, it is the most common form of the intrinsic renal failure. And the profound ischemia injury may result in the bilateral cortical necrosis. If it persists for the prolonged time, that is called, can cause the bilateral cortical necrosis. If once bilateral cortical necrosis occurs, it is very difficult to reverse back the condition. যেটা বলছেন যে if there is any obstruction to the urinary outflow tract, then can cause the post-renal causes of the acute renal injury. যদি সিঙ্গেল সাইডে থাকে, if there is the single side obstruction and another side is normal, another kidney is normal and there is the obstruction of the single kidney or single outflow tract, that can cause the urinary acute kidney injury. So both side or posterior urethral valve obstructing the urinary blood flow tract obstruction or the acute stone in the junction of the uteropelvic junction or the bladder junction, that causes the hydronephrosis and causes the acute kidney injury. Any obstruction, mechanical obstruction or the functional obstruction to the outflow tract obstruction can cause the acute kidney injury. That is the post-renal causes of the acute kidney injury. History taking. কি ডিমান্ড হিস্ট্রি তো তুই জিজ্ঞেস করবি ফার্স্টে নাকি? হিস্ট্রিতে আবার দেখবি কি? History taking. Any nausea, vomiting, diarrhea or any known case of the heart disease or liver disease or the previous renal disease or kidney stone. Many patients known cases of the liver disease, previous renal disease or any recent illness. Recent illness means any sore throat. Last day we discussed the acute post-streptococcal glomerulonephritis after the throat infection or the pyoderma in the skin, that can cause the acute post-streptococcal glomerulonephritis. So any recent illness, that is the any skin infection or any throat infection. If there is the gap between the throat infection and the post-streptococcal glomerulonephritis, if it occurs within 2 to 3 days after sore throat, hematuria, patient present with hematuria, that is due to the, not due to the post-streptococcal glomerulonephritis, IgA nephropathy, very good, IgA, Barjatis, IgA, that is the, if the duration is short, then we can suspect about the IgA nephropathy. If the duration between the sore throat and the hematuria is prolonged between 2 to 3 weeks, then we can suspect about the post-streptococcal glomerulonephritis. So we should ask about the any recent illness or any snake bite is there or not, any drugs, nephrotoxic drug, any antibiotic or nephrotoxic drug কি কি আছে? Tell me some example of the nephrotoxic drug. Amikacin, analgesic, NSAID or COX-2 inhibitor, antibiotic, vancomycin, amikacin, aminoglycosides group of antibiotic, vancomycin, that causes the renal injury, that is the nephrotoxic drug. Any recent radiology studies means contrast, maximum contrast are nephrotoxic, So after the any recent radiology intervention done and patient present with oliguria, then we suspect about the drug induced acute renal injury. Rashes or arthralgia, if any rashes, rash থাকলে কি হবে? HSP, maybe the HSP. If there is a purpuric spot on the extensor surface of the lower limb, maybe the HSP. Or in case of the hemolytic uremic syndrome, patient may present with rashes, or in case of the SLE, systemic lupus erythematosus, SLE, there is the many type of rashes. So we should ask about the rashes or photosensitivity, butterfly rash, and arthralgia. In case of arthralgia কার কেসে পাবো? Arthralgia, bone pain. Arthralgia or arthritis, what is the difference between arthralgia and arthritis? Arthralgia means only pain in the joint, and arthritis along with pain there is the signs of inflammation, that is the redness, swelling, any collection of the joint, restriction of the movement, that is present in case of the arthritis, and in case of the arthralgia only pain, no signs of the inflammation. Signs and symptoms, nausea, vomiting hote pare, hyperkalemia. If there is the hyperkalemia, patient present with ki hoy hyperkalemia, which system is affected in the hyperkalemia? First, cardiac, that can cause the bradycardia, and if potassium level is more than 7.5, it can cause the asystole and the death. So in case of the acute kidney injury, electrolyte disturbances and the fluid management is mandatory. So most dangerous is the hyperkalemia. That can cause the asystole or the bradycardia. So bradycardia along with ECG findings, tall T wave, that is the findings of the hyperkalemia. Bradycardia along with tall T waves, that is present in the hyperkalemia. How you decrease the potassium level in the blood? যদি hyperkalemia পেলাম কি করব? That is the very dangerous thing. That can lead to death, hyperkalemia. First, what is the different mechanism to decrease the potassium in blood? Insulin. Before that, to stabilize the cardiac stability, cardiac stability, what beta blocker dile কমবে, that can cause the hyperkalemia, decrease the potassium level in the blood. But to stabilize the heart, first we give the calcium gluconate to stabilize the heart, সেই জন্য first calcium gluconate, then we should give the insulin along with glucose or beta blocker or many other drugs, sodium potassium binding drugs, calcium sodium binding drugs বা ক্যালসিয়াম পটাশিয়াম বাইন্ডিং ড্রাগ, রেজিন যেগুলো থাকে ওরালি দেওয়া হয় যেগুলো, potassium binding যে substance, we can give to the patient. Another is the nebulization can cause the hypokalemia, decrease the potassium level. Most rapidly decrease the potassium level by insulin and the glucose. Insulin or glucose dile most rapidly potassium absorbed in the intracellular space from the extracellular to the intracellular compartment, তাই তো? ইনসুলিন কি করে? ইনসুলিন আর গ্লুকোজ potassium from the extracellular to the intracellular space. Pulmonary edema due to the volume overload. In case of the acute renal failure, urinary output is decreased. If there is the volume overload, then cause the pulmonary edema. Ascites, asterixis, what is the asterixis? কেউ বলতে পারবে অ্যাস্টেরিক্সিস? ঠিক বলছিস, you are saying the right thing. বল। কোথায় দেখেছিস? in case of the asterixis কোথায় পাওয়া যায়? in case of the hepatic encephalopathy or uremic encephalopathy, any encephalopathy. In case of the renal failure or hepatic failure, any encephalopathy can cause the asterixis. If we stretch the wrist যদি এরকম ভাবে স্ট্রেচ করি তাহলে কি হবে? ফ্ল্যাপিং মুভমেন্ট, ফ্ল্যাপিং এরকম করে নামবে। হ্যাঁ, দ্যাট ইজ দ্য অপোজিট অফ দ্য মায়োক্লোনাস। মায়োক্লোনাস যেরকম এরকম হয়, এরকমভাবে হয় তো মায়োক্লোনাস। মায়োক্লোনাস দেখেছিস কি, জাস্ট ইলেকট্রিক শক লাইক মুভমেন্ট, হঠাৎ করে বাচ্চাদের এরকম করে কেঁপে গেল। অনেক সময় ঘুমোতে ঘুমোতে হয়। স্লিপিং বিনাইন মায়োক্লোনাস ইজ কমন ইন নিউবর্ন। স্লিপিং সময় যদি ডিপ স্লিপে যদি মায়োক্লোনাস হচ্ছে, হঠাৎ করে বাচ্চা দেখবি ঘুমোতে ঘুমোতে হঠাৎ করে এরকম করে শকের মতো কেঁপে ওঠে, ইলেকট্রিক শক। দ্যাট ইজ দ্য স্লিপিং বিনাইন মায়োক্লোনাস, দ্যাট ইজ দ্য নর্মাল। কিন্তু যদি এরকম মায়োক্লোনিক সিজার হয়, দ্যাট ইজ দ্য ইলেকট্রিক শক লাইক মুভমেন্ট। সেটা কি হয়, এবার ফ্লেকশন হয়, অপোজিট দ্য অ্যাস্টেক্সিস। এখানে কীরকম মুভমেন্ট হবে, এই পাশে হবে, জাস্ট লাইক দ্য অপোজিট টু দ্য মায়োক্লোনাস। মায়োক্লোনাসে এইভাবে হয়, আর এইভাবে এটা এইভাবে। ইন কেস অফ দ্য হেপাটিক এনসেফালোপ্যাথি or uremic encephalopathy, that is the sign of the dehydration, dry mucous membrane and the decrease the peripheral circulation, low blood pressure or the capillary refill time low, that is the or low volume pulse, that is the volume status, and the cardiovascular system examination. If there is the volume overload in case of the acute kidney injury, that causes the JVP, RAS, tachycardia or gallop rhythm, and the pulmonary edema. Pulmonary edema is the decreased bass sound, reals, এগুলো পরে পড়বে। আর র্যাশ or arthritis, HSP আর SLE. In case of the SLE and HSP, rash and arthritis, এগুলো জানিস due to the pulmonary physical examination of the pulmonary edema and the cardiovascular overload. Laboratory findings. Laboratory findings increase the urea and the creatinine level and the potassium and the phosphorus level. আর কি পাওয়া যায়, এটা তো সবাই জানে যে increase the urea creatinine level. Anemia, if there is the anemia due to the dilutional anemia, and in case of the SLE or the hemolytic uremic syndrome or the renal vein thrombosis, it is due to the hemolytic cause, and leukopenia is the features of the SLE and the sepsis. If there is the severe sepsis, then it is the leukopenia. And thrombocytopenia present in the SLE, HVS, RVT and the sepsis. And lichen, anemia is the dilutional or the hemolytic anemia due to the SLE or hemolytic uremic syndrome or the renal vein thrombosis. If we detect the leukopenia, we can suspect the SLE or sepsis. If thrombocytopenia persists, then we suspect the SLE or hemolytic uremic syndrome or renal vein thrombosis or sepsis. If there is a sepsis, there is the features of the infection. In case of the right vein thrombosis, there is the palpable renal mass and the hematuria, and also the thrombocytopenia, abdominal pain. In case of the SLE, there is the rash, arthritis, arthralgia, along with the thrombocytopenia, leukopenia and the anemia. 3 cell lines are affected in the SLE. 3 cell lines: anemia, leukopenia and the thrombocytopenia. 3 cell lines are affected in the SLE. But in case of the thrombocytopenia, in the hemolytic uremic syndrome and the renal vein thrombosis. So we can differentiate from the laboratory findings and also from the physical findings, physical correlation, what is the cause of the renal failure. Decrease C3 level. Last class we have discussed serum, decrease serum C3 level in case of the post-obstructive glomerulonephritis, transient decrease of the C3 level. If it persists with the membranoproliferative glomerulonephritis or SLE. In case of the SLE, decrease C3 level. and post-streptococcal glomerulonephritis. Antibody against post-streptococcal glomerulonephritis, nuclear, GPM, কি দেখি SLE তে অ্যান্টি ডবল স্ট্যান্ডার্ড ডিএনএ অ্যান্ড অ্যান্টি নিউক্লিয়ার অ্যান্টিবডি, তাই তো? অ্যান্টি নিউক্লিয়ার অ্যান্টিবডি, অ্যান্টি ডবল স্ট্যান্ডার্ড ডিএনএ থাকে। আর যদি ইয়ে থাকে জিবিএম, গুড পাস্তুর সিন্ড্রোম, antibody against the GBM, and in case of the Wegener's granulomatous or microscopic polyarthritis, it is the Sianka and the Pianka. Sianka and the Pianka. So that is the different detection of the antibody to diagnose the disease, to diagnose the pathology. Arekta important, this is the, if there is the RBC cast present, if there is any cast, it is renal pathology, glomerular or the interstitial pathology, tubulointerstitial pathology or the glomerular pathology, that is the renal pathology. If any cast is present, if it is the RBC cast, it is the intrinsic renal failure. If it is the WBC cast, then the tubulointerstitial disease. এটা মনে রাখবে, RBC cast intrinsic renal failure and WBC cast tubulointerstitial disease. In case of the drug induced tubulointerstitial disease, eosinophil, urine eosinophil should be present in the urine, eosinophils. If any drug injury causes the renal failure and the drug induced tubulointerstitial disease, then cause the eosinophil in the urine, eosinophil in the urine. Dress syndrome, that is the drug induced syndrome, hypersensitivity reaction, one type of allergic or hypersensitivity reaction. In case we can detect the eosinophil in the urine. If drug induced tubulointerstitial disease, eosinophil should be present in the urine. In case of the WBC cast, we can diagnose the tubulointerstitial disease, and RBC cast intrinsic acute renal failure.